So colleagues, good morning and welcome to this Usher COVID-19 webinar. My name is Linda Ball, Professor of Public Health in the Usher Institute. I'm really delighted that you're able to join us today. This is our last webinar in the series. So we have two excellent speakers joining us, and most of you, I think, who've registered via Zoom have joined us before, and you know the process. If you do have questions for our speakers, and please, I do encourage you to think of a couple of questions as you listen to the seminars, the webinar. Just pop them in the Q&A box on the bottom of your screen, and then I'll choose some questions to ask the speakers at the end. And if you would like to hear some of the questions answered, do use the thumbs up sign that's beside other people's questions to indicate you're also interested in hearing the answer to that. The webinar is being recorded and is being live streamed via YouTube, so do pass the link on to other colleagues afterwards if you think they would be interested. And for future events in 2021 from Usher generally, do have a look at our website, which is on the screen. So I'll now introduce our two speakers. I'm really delighted they've been able to join us. So we're going to hear first from Dr. Naim Shazad, who is Head of Department of Disaster Management at the National University of Sciences and Technology in Pakistan. So he's an expert in disaster management, also climate change and the environment and sustainable development. He has a background in environmental engineering, and he's been involved with the department since its inception in 2012. He's published extensively, but the most relevant, he recently had an article published in the Journal of Global Health. I think Professor Igor Rudan has joined us, who's the editor of that, and that was very topical in terms of COVID-19. So he'll be our first speaker, and then our second speaker is Raaj Kishore Biswas, who's a statistician by training, and he's completing his PhD at the University of New South Wales in Sydney, originally from Bangladesh, and his areas of expertise are biostatistics and public health policies. Again, he has recently published in the Journal of Global Health, specifically on the issue of COVID-19 preparedness in Bangladesh. So really looking forward to hearing from him as well. So I'll now hand over to Dr. Shahzad, who's going to speak first for about 20 minutes, and then we'll hear from Raaj. So over to you. Thank you for joining us.
Thank you, Dr. Linda, for this nice introduction and for your kind support throughout this, the working which we have done for preparing for this seminar. Good morning and good evening to everybody who are listening to us right now. Thank you very much to the Usher Institute and the University of Edinburgh for extending me this opportunity to present a talk on a very important topic in the next 15 to 20 minutes. I'll be discussing how Pakistan has responded to COVID-19 through public health interventions and the corresponding public policy issues. I'd also like to mention here that there is not a single statement which is my own, and all this information which I am sharing with you have been derived and from the different research studies which I have referred to at the end. I am basically, as explained by Dr. Linda, I am basically a expert in disaster management. So I will be more focusing and looking at the response with respect in the lens or through the lens of the disaster managers, not through the lens of a typical MBBS doctor. So please bear with me in this one. I'm going to share my screen with you right now. I hope the screen is visible to everybody.
Yeah, that's perfect. Thank you.
Okay. So the start of the pandemic in Pakistan was on 26th February when 2 cases were detected. Both of them had traveled abroad, and within the 45 days, cases reached to 4,600 and resulted in deaths of 66 individuals, while 727 of them recovered. Immediately to contain the virus, the government of Pakistan closed international borders on 13th of March 2020, and correspondingly all the schools and the educational institutions were also closed on the same very day. Later this month, a countrywide lockdown was imposed throughout the country. This is a context of the Pakistan's healthcare system. We are at level 2 as far as the WHO classification is concerned in terms of health system to cope with the effects of pandemic. Unfortunately, only above a few sub-Saharan countries. Pakistan spends 2% of its national GDP on healthcare as compared to 10% of global average. And the fewer healthcare professionals are available in Pakistan per head of population than in any other country. You can see from here that one physician is available for every 963 population. Besides this, 1.6 pharmacists are present for 10,000 persons, in contrast to 5 pharmacists per 10,000 population as recommended by the WHO. 70% of the health services are provided by the public health sector. The initial challenges which we faced were the major one were the lack of medical facilities. And you will be amazed to know that during the initial stage of pandemic, Pakistan lacked these medical facilities and the suspected samples had to be sent to China. We had developed only a few quarantine centers, and that too with very limited diagnostic and treatment facilities. Many drugs and equipments went short in the supply, short supply in the market due to growing threats and the danger and the fatalities growing all across the world with regards to the COVID-19, and the demand increased and subsequently the supply decreased. The health and care staff was stressed, laboratory facilities were strained, and emergency rooms came under strain with the COVID-19 patients in different hospitals all across Pakistan. There were certain organizational policy gaps as well, which included the legislation and policies regarding infection control and prevention were far below the international standards, although Pakistan developed its first international infection guidelines in 2006, but the implementation and compliance has been an outgoing challenge. The public health facilities did not have formal standing operating protocols, SOPs, that meet or that met the national guidelines on hospital infection control and prevention. The general public valiantly flouted government orders, underplayed the threat, and took it casually. And in addition to this, misinformation circulated, reinforcing the violations of lockdown measures. A particular issue was that some individuals perceived that the pandemic was a conspiracy to prevent religious practices. Unfortunately, this myth has already prevailed as far as to response to the polio vaccination is concerned. People believe that it's a conspiracy against our religious practices, and still many people are reluctant to administer that polio 19 vaccination to the people. And the same case is with this COVID-19 vaccination or COVID-19 response, or taking care of the SOPs and wearing masks and etc. So these actions contributed to the transmission of virus in different parts of the country. We have certain community level issues as well. About 25% of the people in Pakistan are living below the poverty line, and that's why they have poor hygienic practices in those areas. There are low levels of literacy in some parts of the population, which creates problems as far as the addressing the COVID-19 and awareness regarding the COVID-19 issues are concerned. 2/3 of the population of Pakistan live in rural areas. As I've already told you that we have a weak health infrastructure, and once the complete system is weak, then that the rural healthcare centers are going to be neglected, and they are inadequate to cater for the needs of the rural communities. Pakistan started off with an initial response by developing a national action plan by the Ministry of National Health Services Regulation and Coordination back in 12th February 2020. And the major roles or the major tasks assigned to this through this action plan were to set out measures to control the spread of the COVID-19 virus and to identify mechanisms to strengthen the country and community emergency preparedness in order to ensure a timely, efficient, and effective response to COVID-19. Subsequently, National Command and Operation Center, NCOC, was established in early April in 2020. This became a nerve center with regards to Pakistan's response to COVID-19. It immediately took over the task of compilation of robust data and the use of technology to help understand COVID-19 and drew different and various insights from it. It gave clear and effective public messaging and behavior change guidance to the stakeholders, and it developed coherent and cohesive governance to ensure consistency and predictability in the national response. Mass awareness campaigns through social media, different channels, even to the extent that ringtones are transformed to deliver warning messages against COVID-19 waves and hampering on following of the different SOPs and guidelines issued by the government. The polio staff, which became redundant because of the lockdown measures and the vaccination had to be stopped. So they were engaged to engage shopkeepers, grocery stores, retailers, mosque imams, down to the local level to address issues arising from the relaxation of the lockdown. The polio helpline 1166, which was being used for polio, was used for COVID-19 for assistance and managing of different issues which arise with regards to this COVID-19 virus in the community. There was a massive media orientation and mobilization to create awareness among the masses and to take the certain SOPs and the measures enforced by the government seriously. We also got support from various international organizations, including the WHO, UNHCR, FAO, UNDP, and so on and so forth. Pakistan took some public health interventions. WHO established test centers for COVID-19 in 7 hospitals all across the country. The OPDs and the elective surgical services from mid-April 2020 were closed in all the tertiary care hospitals, the district hospitals, and the private clinics. The testing capacity was gradually increased, and it varied between 30 to 50,000. The last, the SITREP which we have received had 34,000 tests which were carried out in Pakistan. These are the designated hospitals which were designated by the government for COVID-19, particularly for COVID-19. These are 35 in total all across Pakistan, and the distribution, province-wise distribution is as shown. The highest number is in Balochistan, followed by the Punjab, followed by Khyber Pakhtunkhwa and KPK. The government also set up isolation centers. A total of 224 isolation centers were set across the country, and the number of beds, distribution of number of beds with regards to the different provinces is as shown over here. Besides this, there was 2,357 quarantine centers established all across Pakistan, and the numbers which you are seeing here are the number of beds available in these quarantine centers, in which Punjab tops the list with 10,000 beds, followed by Balochistan and Khyber Pakhtunkhwa. The government established a COVID-19 relief fund to receive donations so that a fund could be generated to meet the eventualities of this response. Government allocated rupees 144 billion for 12 million families under the SAS emergency program for 12,000 each for each family. The electricity and utility bills were subsidized for small and medium-sized businesses. Social network helplines were launched by government in 7 local languages so that the people who cannot and who are illiterate can understand in their local language what were the different instructions and what were the different warnings being issued from time to time by the government. The trace, test, and quarantine strategy was employed all across the country. This strategy applied to both local and imported cases, used technology to track COVID-19 positive people, and through their cellular network locations, and food and text alerts were sent to people they had been in close contact with. And contacts were advised to stay home, with district administration arranged for the home tests, and those who tested positive were placed under quarantine either through home isolation or forced transfer to a government quarantine facility. The countrywide smart lockdowns were implemented in 200 hotspots across 30 cities. This data might be a little old because I've taken it from a paper which was published two months back, but This smart lockdown helped the government to balance the imperative to contain the spread of disease with the need to keep the economy functional. This was lauded by Bill Gates in the United Nations General Assembly's incumbent president, Mr. Volkan. The smart lockdown allowed many businesses to reopen or continue operations on a limited scale to lessen the adverse effects, economic impacts, and to support the vulnerable segments of the society. The funds, special funds were allocated to the provincial and health departments to cope with the different economic impacts which were occurring on the health related issues against COVID-19. The doctors, paramedics, and the medical lab technicians were trained because they were subject to unremitting stress and experiencing psychological issues of anxiety, fear, panic attack, post-traumatic stress symptoms, and so many other issues. And besides the isolation from the family, social support, and concern regarding contagion exposure to their friends and families, and they were trained to handle the patients under these testing circumstances. The standard operating protocols were developed nationally for the health department, and there are a number of activities, a number of different activities which are going on in Pakistan. These SOPs have been issued by the government, and these are all available on the dedicated COVID website, which Pakistan is maintaining. And any of the SOP regarding any of the activity you want to carry out can be assessed from that website. Pakistan also launched a terrestrial television channel to meet the educational needs of the students from kindergarten to year 12. This was important because the school-going children, many of the school-going children were from a low economic background. They could not afford the internet facilities and the computing facilities. So the majority of Pakistan has access to a television. So that's why a dedicated channel was launched in order to meet their educational needs of the children, especially from the kindergarten level to the level 12. Okay, these are the broad strand. This is the broad strand of Pakistan anti-COVID-19 strategy, which involves the national awareness, starting off from the risk communication, awareness of guidelines, the SOPs, and reducing panic, and there to, after managing the economic and socio-economic fallouts by implementing special ordinances for anti-hoarding and smuggling, the economic stimulus package, which I have already discussed, the SAS program, the disease prevention and containment through the trace, test, and quarantine policy, the smart lockdowns, the SOP compliance, and the healthcare optimization and build up, because we had very limited healthcare facilities. So we had to optimize it to use it in the best possible way to effectively respond to this COVID-19 disaster. And in that case, a 300-bed quarantine center was established in Islamabad within a week, and it became an integral part of our society, coupled with the smart lockdowns in high-risk areas and hotspots and SOP compliance. And those who violated these SOPs were fined or the businesses were sealed. Okay, this graph shows you how the things progressed as far as the declining case positivity percentage is concerned. If you can see on the left side, in the month of May, the lockdown was relaxed under phase 2. The lockdown was imposed, as I've already told you, that it was imposed in the mid of March. That would, in the next slide, you will be able to see that with regards to the number of growing cases. But once the lockdown was relaxed, and a big event as far as the religious event is concerned, that is Eid al-Fitr, that was being celebrated in Pakistan. And the result was a growing number of the positive cases immediately after this event, because the people of Pakistan were stranded and they were far away from their houses for about 2 to 3 months. So they rushed back to their families, and they that resulted into mass gatherings and spread of virus. And you can see from here that in the start of the June, Pakistan reached its peak as far as the COVID positive cases were concerned. Government took the measures, and they enforced the SOP compliance, and they also issued directives for mandatory use of masks in mid-June. And correspondingly, the number of cases then started to decline, And towards the in the start of August, another religious event. There are two religious events which are celebrated all across Pakistan: Eid al-Adha and Eid al-Fitr. And once the second event came, that was Eid al-Adha, followed by 14th August Independence Day celebrations, the cases did not increase and it continued on the declining slope. And after that, this could be marked as the end of the first wave. But after that, the government was still on high risk, and they kept high vigilance as far as the COVID cases were concerned. They were also evaluating the impact of the removal of the lockdowns and the restaurant and tourism activities which were restored. The schools were again opened on 15th of September. They were also looking at the Muharram impact. This is another religious event which results in very mass gatherings all around the country during this period. But the cases remained within few hundreds, and there was nothing to worry about till October, once the cases again started. That was the start of the second wave. This is another visualization with regards to the number of mortalities. You can see on the left side, leftmost, with mid of March, lockdown was imposed. And in the mid of April, or rather the second week of April, the lockdown was relaxed of phase one. That took around 1.5 months for a complete lockdown. All the activities in the country were completely stopped. Stopped throughout Pakistan. And you can see from here that the number of cases still went on increasing, and Pakistan adopted the trace, test, and quarantine strategy, which was then followed by the lockdown, relaxing of the phase two, and the event of Eid al-Fitr. And after that, the cases or the death rates jumped in Pakistan, and it reached the peak by the end of June, or in the third week of June. And afterwards, the SOP compliance and mandatory use of masks was enforced, and the smart lockdown was enforced throughout the country, and which followed till the number of cases went considerably down, and the first wave ended. This is the present situation with the data I've taken from the National Command and Operation Center website. The confirmed cases, this has been taken from the SITREP of 15 December. The confirmed cases in Pakistan are 4,443,000, and while the recovered cases are 386,000. That the deaths which have experienced is 8,900 in Pakistan, 2,400 still are critical. On the right side, the map is showing the province-wise distribution of the positive cases. Sindh is topping this one, 190, close to around 200,000 cases in Sindh, followed by Punjab and then KPK. But the case a little bit reversed as far as the deaths is concerned. In Punjab, there are around 3,400 deaths as compared to 3,100 deaths in the Sindh till yesterday. Okay, one must imagine that despite having all these odds, very weak health infrastructure, very vulnerable population, the death rate in Pakistan and the positives and the cases in Pakistan are still on the lower side. The average age in Pakistan is around 22 years as compared to 41 years in UK, and 4% of this population of Pakistan is above 65 years. That means that I would like here to let you know that 78% of our population, of our deaths which have been recorded till to date, are the people who are aged 50% and above. And among them, 77% were those who had comorbidities which aggravated their COVID-19 conditions. The other one factor could be that the majority population are living in rural areas. This could be a reason for because the living style in the rural areas is quite different in Pakistan as compared to the urban areas, and for that matter, there are lesser number of high density areas in high population density areas in urban areas in rural areas as compared to the urban areas. Moreover, the habits of going out or recreational activities or moving around or gatherings is far less as compared to the in far less in rural areas compared to the urban areas. And thirdly, there are very open and vast areas in the rural settings in Pakistan as compared to the urban areas. So this might have a major feature in the lesser number of the positive cases and lesser number of deaths. Okay, this is another, we have published a paper regarding the regional meteorological parameters having the effect on the COVID-19 global spread all across the world. And we found some very positive relationship between these parameters, because the countries with lower temperatures, with lesser daytime lights, with lesser temperatures, the spread of COVID-19 was very fast as compared to the other countries. I have referred this paper. You can always go to that and you can study that. You can to have an idea what I'm talking about. Okay, and another a factor which could be a factor. I'm not I'm not debating. I'm not. You can say I'm not asking. I'm not giving a statement regarding this, but I'm following that it might be so that the majority of population in Pakistan are Muslims, and they practice a hygiene ablution 5 times a day for offering the religious prayers, and these involves each ablution involves 3 times gargling, 3 times washing of your nose, 3 times washing of your face and your eyes, washing of your hands up till your arms, and it makes 15 times a day, every day. I'm not giving a statement or an argument to support it, but the 3 different papers have been carried out to investigate this phenomena, that this might help in the lowering the COVID-19 cases in Pakistan. One of the study has been published in a newspaper in UK, in which Dr. Webbert of Newcastle University and and Mr. Peter Trevos also were of the opinion that the reason behind the lower number of cases as far as the Muslims in UK were concerned could be that they observe this religious practice 3 times a day. Okay, the self-medication issue is a bit controversial. I'm not advocating that, but it might be affecting the way the people are responding to the COVID-19 virus, because in Pakistan there is no check as far as the use of antibiotics and steroids are concerned. People are free to get these medicines from the drug stores at their own will and wish, without the prescription of the medical practitioners, and this might have developed some sort of resistance against the microorganisms, which might have helped in reducing the causes. Okay, the issues which I have highlighted over here, these are just the food of thoughts which need further research. I am not claiming that these might be the factor, but these research could always be carried out in these directions in order to evaluate whether all this is corresponding to what I'm saying or not. Okay, in the response, the summary, Pakistan is coming up with an innovative smart solution, exploring the use of technology to create awareness, mitigate the risks, and contains the shocks created by such pandemics as COVID-19. Ensuring food security and access to a safety net are just as critical as having a sound health system. Our government plans to temporarily abolish all taxes on food items and has announced a significant reduction in oil prices. The economic stimulus packages contains a whole range of fiscal measures, from tax breaks, financial support via utilities, fuels and transport subsidies, and so on, to protect the exporters and businessmen. And we are supporting the healthcare facilities by providing them PPEs, disinfection items, awareness posters, triage tents, and we are also providing the technical guidance to the hospital management, and online medical consultation is also available. We are ensuring the safety and protection of healthcare workers by raising awareness, through digital and field campaigns where government is lobbying to promote laws and policies to protect healthcare against violence. Azad Jammu and Kashmir has awarded a Nishan-e Pakistan, an award for a Pakistani young doctor who died. He sacrificed his life at 26 years of age against fighting against COVID, right in the start of this virus. That was on 23rd of March. And we have adopted a whole nation approach by incorporating every individual so that they take the onus in responding to these disasters. In the end, I'll be sharing just a small graph which shows the daily confirmed COVID-19 deaths. You can see from here that Pakistan is good as far as neighbors are concerned. China has already controlled that, but Afghanistan it has a lesser number of deaths, but it is far more as far as Iran and India is concerned, although the curve is declining, but still the numbers are quite considerable as far as Pakistan is concerned. This is a comparison of between UK and Pakistan. You can see from here that the daily confirmed COVID-19 cases per million people. The only period where it came below Pakistan was the time in mid-June when Pakistan was peaking as far as the confirmed cases of COVID-19 was concerned. But now there is a huge difference as far as the confirmed cases of COVID-19 between UK and Pakistan is concerned. In the last, I'd like to share some interesting facts. Because we advocate that social distancing is a major issue we need to take care of. But this, on the left side, this is the funeral of Maulana Khadim Hussain Rizvi, who is a TLP leader. You can see the huge gathering which took place on 22nd of November in Lahore. But after 2 weeks, that was 14 days, the Lahore positivity rate was 4.74. And similarly, a mass gathering was carried out in Gujranwala on 13th November, but the latest positivity rate of is less than 1%. I'm just leaving you with this thought, and this is the end of my presentation. Thank you very much for bearing with me, and I'll be very happy to answer your questions at the end of this session. Thank you once again.
Thank you very much, Dr. Shahzad. Really appreciate that. So now we will hand over to our second speaker. So over to you. Thank you very much.
Hi, everyone. So as Linda said that I'm a statistician, so you will see me more looking into the data of Bangladesh and how Bangladesh, the timeline of Bangladesh, the interventions they have allowed and how the data has changed over there. So I'll be looking into test cases and deaths. So before I go into the data itself, there are a few acknowledgements and disclaimers that I want to put out. Firstly, the frontliners, the doctors, the nurses in Bangladesh and everywhere else, they have been instrumental, and their fight to the pandemic is something that would be remembered for ages to come. In Bangladesh, up till last week, we have lost 113 doctors up till now. So that's one of the major issues that needs focus as well. And I have few colleagues in Bangladesh and also worldwide who has helped me with few of the publications that I will be discussing today. So their field level experience is something that has helped me. And data and reports that came out of IDCR, ICTDRB, BRAC, and others. So those are the data that I'll be using today and explaining them. And as I go along, and IDCR is the government, part of the government body who has been regularly releasing the data. So a huge acknowledgement to them for releasing the data that we have today. And the data that I have is mainly from Johns Hopkins Resource Center and the European Center for Disease Prevention. I'll be also using the situation reports that were weekly coming out of WHO and also the published studies, of course, and the media articles. So this is the first glimpse of the cases and deaths. So one of the important issues in this graph is that on the left-hand side, we have the cases, on the right-hand side, we have the deaths. So it's a double y-axis graphs. So please do take care when you're interpreting the graph itself. The cases are in blues, that they have increased in June and July, and in August, they have gradually declined, and now they seem to be increasing as the winter progresses. And the deaths are the red lines, and do take care on the indication on the right-hand side. This is from 0 to 200. So So the deaths doesn't necessarily mean the red lines are 20% of all the cases. This is far lower than that, but this visually is more easier to understand. So up till now, Bangladesh have around 490,000 cases and they have around 7,000 deaths. So one of the interesting timelines that have happened throughout this is the airport alert Bangladesh have put up was back in 22nd of January. This was regarding all the arrivals from China, just to have a screening from them. And then at that time, just in 22nd of February, a flight from Wuhan came in. This was all the stranded Bangladeshis, 312 of them. They were placed in institutional quarantine and none of them were found positive. So this was the time Bangladesh was already preparing and we did not have any positive cases at that time. So the first confirmed cases came in on 8th of March and the first death on 18th of March. So Bangladesh almost had 2 months to prepare for all of these. Now, the interesting event of all of these is the returnees from Italy. That was in 8th of March. The difference between the Wuhan flight and the Italy returnees were the Italy returnees had families in them. And interestingly, they did not want to be part of the institutional quarantine. So what happened is they protested and they were allowed to do home quarantines. Later on, some of them were tested positive, and in subsequent weeks, we had more flights coming in from parts of Europe and Middle East as well. These were the skilled migrant workers that actually worked there. So they came back, and then there, unfortunately, because of the media reports that we later on learned that few of them did not maintain the quarantine, the home quarantine properly, there was a floodgate opens, and that's why the community transmission that you see over here. And then if you look into the deaths, right? So this is where we published one of our papers, and huge thanks to Awan Afiaz and Samin Haq, two really excellent people that I worked with throughout this pandemic on multiple papers. So it was a part of their idea that when we looked into the number of deaths or number of tests in Bangladesh, you'd see that while the number of tests were going quite up and down at some point, number of deaths were always between 0 to 40. And if you look into the later 90% of the death cases, the percentage of death by cases were 1.5%. That was the mean. And the median was 1.4. And as I said, the range between 0 to 40. While this could be it could be applauded that Bangladesh have controlled the number of deaths per day. However, this also gives us a question whether the numbers were underreported or not. So we had several media reports come out, and one of the concerns we published in Epidemiology and Infection is about the whole Indian subcontinent. Because at this time, the number of deaths that were, the number of people that were listed in the burial grounds or crematoriums were 3 times than they were in the previous months. So this got to us thinking that whether we are truly capturing the infectious rate in Bangladesh or not. And one of the problems with low death rate is it gives to a false pretenses. For example, there were reports coming out thinking that Bangladeshis are perhaps more immune because they had BCG vaccines in their life. They were thinking that high temperature in Bangladesh may be a protective factor for it. The problem with underreported data is that you can prove any and every hypothesis if you want to, if you model them. So this is where we needed to look into the number of tests, right? So one of the disclaimers here, again, just like the previous slide, the tests are on the right-hand side. These are on the green line. Do notice that the number of tests are from 0 to 20,000. And all the tests out that are reported here are PCR tests, except for the last 5 days, because I have reported here all the results up till 11th of December. So the last 5 days, that is since 5th of December, Bangladesh have allowed antigen tests. So those are actually complemented with the PCR test only for the last fraction. Apart from that, the rest are from the PCRs. So the number of tests Bangladesh has done in terms of, in ranking, Bangladesh would be 46th, whereas total number of cases, Bangladesh ranks 26. So did Bangladesh do enough tests to actually truly portray the scenario of the pandemic that could be questioned. Now, Bangladesh is a population of 170 million with one of the top 10 densely populated country in the world. So this is where the number of tests need to increase. Now, if you see that the tests have been following the cases have been following the test trend. So as the test increase, the number of cases also increase. This kind of complements the famous Twitter theorem from Donald Trump that the more tests you have, the more cases you get. So this is what happened at least from March to August. However, one of the interesting thing is this is where that seems like an apparent success that after April, the number of tests did not decline. There was always over 10,000 tests per day. However, number of cases did decline out here, as you can see. So this tells us that maybe there are some positive intervention that happened and that actually helped Bangladesh. Whereas these were the areas where there was crucially not Bangladesh wasn't doing very well. But before we look into the successful intervention, there are two important incidents that happened back in late June. One was Bangladesh started to charge for the test. Now, charging for the test was quite unprecedented because no other neighboring countries, at least in Southeast Asia at that time, was charging for any PCR test, at least in government facilities. So at that time, Bangladesh started to put in a cost for the PCR test in government facilities that was $2. And for private facilities, it was $32. And what was the explanation from the authorities? What they wanted to quote unquote avoid unnecessary testing. So while the country was at the peak of its pandemic, the authorities decided not to have any unnecessary tests. So that obviously declined the number of tests, as you can see, because the lockdown previously, I will go into the lockdown part, the lockdown previously had worsened the economy. So a lot of poor people who would have gone into seeking tests in government facilities were not going to do that. And another event happened at the late June was international flights open. Now these flights were these are the expatriates who actually came back to Bangladesh when there were high number of cases in parts of Europe or Middle East. Now these skilled migrant workers are going back to their working areas, right? So firstly, the flights opened for Doha and London and subsequently for China, Sri Lanka, and parts of Middle East and Europe. What interesting was here, this international flights required them to have PCR tested and a negative COVID certificate. So there could be a scope that a lot of those negative tests that we can see out here could be complemented from them. Now, what were the interventions, the successful and the unsuccessful ones? So these were the first lockdown period and the ever countrywide lockdown. So Bangladesh government actually called this, instead of a lockdown, as a countrywide general holiday. So this started in 26th of March and went up till 31st of May. So when you look into that blue shaded area in this intervention actually tells you an opposite story than you would like to see, because the number of cases actually increased during lockdown. And it's because there were multiple mayhems that happened. And one of the particular ones was regarding ready-made garments factories. So while the lockdown was enforced and the government shut down all the factories, ready-made garments is one of the money earners for Bangladesh and one of the most important economic sector for Bangladesh. So when the factories were closed down, tens and thousands of workers, mostly women, had to go back to their ancestral villages because they couldn't afford to stay in urban areas where most of the facilities are located, factories are located. But they were not paid. So unfortunately, the government then announced that by 16th of April, all the factory owners must pay the RMG's workers, so the ready-made factory, garments factory workers. So they now rushed back to the factories which are in metropolitan areas, and they were paid in some cases and some were not, and then they went back to their original ancestral villages. So during lockdown, the very thing that actually stopped the transport system was not working because of these mayhems that actually happened. So one of the suspicion is at this time, the community transmission actually increased, and throughout the country, it got spread. So one of the things that the Bangladesh government then did is that they stopped the lockdown in 31st of May, as I said, and they went on to zone-wise lockdown in 9th of June. Probably this was a better choice, although it did not go on for a longer time, as you can see with the red shaded area, but it continued up to in many peripheral areas. Now, the local government in those areas, like outside metropolitan where there was less dense population, they were actually successful because localized relief distribution by the police, which was done by the Bangladesh government, and then the strong chain of command that was maintained by the local administrators. Those awareness campaigns, some of them worked, and those were some positive learning lessons because the cases, a number of cases were down in those peripheral areas. However, when you look into this graph and say that in August, September, and after August, September, October, the number of infection was low, number of cases, at least positive cases low. There was a study, a sero survey done by ICDDRB and IDCR. And out of the over 3,000 households where they have done the study, they found 74% COVID-19 antibody prevalence in urban slum areas. Now, that finding does not go along with the cases that we see here. One of the problems that created is that gives a false likelihood that we may have reached so-called herd immunity. Now, the very next day, the sensible researcher put out a press release saying not to generalize their findings. Now, the campaigns there were many leaflets and awareness campaigns done all over Bangladesh. And these were some of the screenshots from the leaflets that were handed out. So there were a few things that were done. One mobile app was launched, several website was launched, which updated the incidents in Bangladesh live. And there was a digital surveillance system, the recorded voice services you could hear when you're calling somebody instead of the caller tune. So in a way, the word reached the people, the social distancing idea, wearing masks, all of these went on. There were daily briefing from IDCR, which was quite brilliant. From the start of the pandemic, they used to regularly give us the update about what's happening in Bangladesh. However, it ceased on 8th of August, and the explanation from the health minister was the situation has, quote and unquote, improved. Now, that was the very day when Bangladesh had 3,000 cases and 30 deaths. One might argue it did not improve that much. So we wanted to analyze was the preparedness of Bangladesh and the transition strategy Bangladesh has done. So this was one of the papers that we published, and out here we use the complex adaptive system network and try to find out the loopholes in the systems Bangladesh have developed and where they were successful as well. So one of the highlights from there was the leadership issue. While the public health expert IDCR and ICDRB, they were trying to give out those messages of social distancing, wearing masks, or taking every sort of precautions, including maintaining a hygiene, there were one or two state leaders who would come up and give random statements such as Bangladeshis are immune to COVID-19, they are stronger than COVID-19. The problem is these sort of statements were louder than those awareness campaigns. So this created a bit of hindrance. And there were fake tests and fabricated test results, which ultimately resulted to the quitting of the chief of DGHS Bangladesh. So those events actually changed the public perception. While generally Bangladesh public perception towards their authorities was positive, this was the events, the RNG sector and these events gradually diminished their trust on the government in a way. Because Bangladesh over the years have been very successful public health wise. The MDG goals, a lot of them were achieved under 5, mortality rate, women education, vaccination coverage were excellent on paper. The problem is during this pandemic, there are a few of the wounds that were coming out. For example, the density of healthcare workers. We only have 19 healthcare workers per 10,000 population. So we have 72% of the health expenditure that comes out people's pocket. Now, these are major issues in a pandemic because BRAC have published one of the studies where they have found that 60% people have now gone to under the extreme poverty line from the poverty. So we're a country where 1/4 of the population is living under poverty line, putting cost on the test, and then out-of-pocket expenditure was creating a major issue. So we ran a survey. Currently, the survey findings are under review. And in that survey, we found that 75% of the people, well, there was around 1,000 people in that survey, and 75% had lower trust on the government. And they found out, and they noticed 3 key issues that they reported as the poorly executed. One was the quarantine system for incoming passengers. Second, the garments industry mayhem that I explained, and also allowing the reopening of shopping center just after the lockdown period. So, but they praised the closure of educational institutions like the schools, colleges, and the tertiary education system. All those institutions were closed throughout this. Interesting finding from that survey is those who were aware of the international scenario or closely followed what's happening in other countries sympathized more with the decisions that government has taken. So this is one of the things where we would say that the knowledge of the person and how the message from the public health officials were delivered were not coinciding together. Now, on a higher note for Bangladesh is that the vaccine delivery system in Bangladesh is quite praised. Bangladesh have the capacity of storing vaccine under 25 degrees and a fully functional technology advisory committee. And in the past, we have been very successful in immunization coverages. As you can see in diphtheria, tetanus, polio, and hepatitis, we have done quite well. And also people have high public trust on the vaccination itself, because a study that came out this year used a survey from 2015 where they have shown over 95% of people in Bangladesh, which is the highest in Southeast Asia, actually say they strongly agree that vaccines are important. Now, currently we are running another separate survey where we have seen that people do agree that vaccination would be the way to go, and over 80% agreed with that. However, 90% agreed that we are not doing enough tests. So there is a good point for Bangladesh is that the people are more understanding in a way, have higher public trust on the previous events. However, the current events have taken away a lot of the trust from that issue. But the good thing for Bangladesh is they have already made an agreement with Serum Institute of India, where 30 million doses of AstraZeneca vaccine will be coming in Bangladesh. Unfortunately, Bangladesh do not have the cold storage system for Pfizer or Moderna. So we are depending on the AstraZeneca, and 30 million doses in next 6 months would be a good point for Bangladesh. However, that will not even cover 20% of the population. And before I end, so this is my last slide, I would like to leave you with 2 important key points. One is the data transparency issue. Every time somebody had a personal experience with COVID-19, they would like to compare their experience with the data that has came out from the government. It will not match. However, those who did not have any experience of that, they would be rather complacent. Well, compared to UK, compared to United States, or even neighboring country, India, we are doing well. But the issue is Bangladesh is doing 1 test per 10,000 population, where India is doing 80 tests per 10,000 population. So if we have done 80 times more tests, would the curve be different? Well, educated guess would be no. And the lessons Bangladesh could learn is that from the local government, peripheral areas were more successful. Why were they? So 2021 would be the place where Bangladesh would be using the lessons they have learned from the local government, where the local government reached out to the public and gained more trust, whereas in metropolitans, it wasn't so. So maybe greater data transparency as well as gaining the trust back on people would be the way forward for Bangladesh. So that is all from me. Thank you, everyone. If you're interested in getting the slides or the codes for the preparing the R codes for the graphs, feel free to contact with me. And the studies that I have referred to, they are all available in the website on the left-hand side. And you will get the details of the JOGH papers that I have published there as well, which ultimately ended up me being here. And thanks to Igor for that. Thank you, everyone.
Thank you very much indeed. Thank you, Raj. That was excellent. And now we'll just have some time. We've only got about 6 minutes, but we'll try and ask a couple of the questions. So Dr. Shahzad, if I could ask you to come back onto the screen as well. So let me just start with a question for you, Dr. Shahzad, which we've had several for you. I think I'll ask you 2 questions together, actually. Sandra Martin has asked, you mentioned public information campaigns. Could you tell us a little bit more about the content of those in Pakistan? And also a question from Fiona Doby, Dr. Shahzad, for yourself. Please, could you tell us about the within country travel advice for people in Pakistan? So in other words, traveling around within the country, were there any restrictions on that? So 2 questions for you. Thank you.
Okay, as far as the mass awareness campaigns are concerned, as I already mentioned, that we have carried out mass media campaigns through different channels and social media channels as well. The government had employed around 40,000 journalists, reporters, and bloggers throughout the country and to assist them in carrying out these campaigns. Secondly, I've also mentioned the involvement of the polio workers. The polio helpline was used to assist and to help the different COVID-related issues. And you will be astonished to know that they received around 3 million calls, and the response rate was around 72% as far as the helpline was concerned. Similarly, we have other campaigns as well. The ringtones of the telephones, of all the telephones, are set to a warning. Once you call anybody, it starts off, instead of ringing tone, you get a warning regarding the awareness about the COVID-19 health effects and the following of the SOPs throughout the country. These are besides this, there are a number of brochures, there are a number of information charts which have been deployed at a major major places all around the country, so that people going to those areas could get information with regards to awareness as far as the COVID-19 threats and the issues related to that are concerned. Okay, the answer to the second question is that as far as travel advisory within Pakistan is concerned, at this moment, the transport services have been asked to maintain the social distancing by creating that mandatory distance between the 2 passengers. But as such, there is no bound as far as traveling within the country is concerned. It was stopped initially during the first wave, but since the government is still monitoring that, but still there is no issue with regards to travel within the country. If the transport agencies and the transport services are maintaining the SOPs which have been issued by the government to them, to follow the strict following of the SOPs with regards to COVID-19 issues are concerned, social distancing, wearing of masks, use of sanitizers within those travel modes of travels, and maintaining social distances throughout that traveling mode.
Thank you. Those were very comprehensive answers. I appreciate it. So, Raj, a question for you. Lawrence Greer, Professor Lawrence Greer has asked this. I think it probably applies to both speakers, but I'll ask you about it because I've taken a note as well. Was these zone-wide lockdowns? So, how were decisions made on where they would be introduced? So how big were the areas and how were they enforced? There's a little bit more detail about that because you said that was a more successful strategy, particularly in the second wave.
Yeah, so this one of the issues was that the first zone-wise lockdown was introduced in the capital. So in the capital, the zones were very small, rather than, because in the capital city Dhaka, there were more testing centers and we had more data from the individual areas, like that will be like 5 kilometers areas. So we had information from there. However, that did not replicate for other parts of the country because in distance part of the Bangladesh, or the peripheral areas, the tests were done just from the one district, and they will come to Dhaka and then they will get tested. So in Dhaka, the zone-wise lockdowns were very short, like 5 to 10 kilometers areas. However, in sub-district areas, people were more aware if somebody was tested positive because people were not doing a lot of tests in those areas. There wasn't a lot of PCR labs set up there. So when people knew that there was a particular case, and the news probably spread farther, and also people were more concerned about it. And the local area, and for the local officials, it was easier to control that part because the population density was low. However, when Dhaka zonal lockdowns did not work, the capital city or the metropolitan zonal lockdown didn't work because people, as I said, were struggling with their jobs, with their money. And at that time, we just came from the nationwide lockdown. So people were not listening to the officials. So they were trying to sneak out of these red zoned areas and then go to their jobs or do something like that. So in a way, the successful part comes outside the capital, whereas within the capital, it wasn't that successful.
Okay, very interesting. I think it's very challenging, isn't it? And so we have reached 10 o'clock, unfortunately. We've reached the hour. I wasn't able to ask all the questions, and I know I noted a few others, but I think the important thing was to hear your full presentations and the data that you presented, and we're very grateful for that. So just to thank you both very much, both our speakers. That was very interesting, and I know we've had a couple of comments in the chat box thanking you for your presentations. So please do stay on the line, and we'll have a wrap up, the three of us, in a moment. So just to thank our delegates, our attendees, and in fact everybody who's attended the 24 COVID-19 webinars we've organized since March. You can find all the webinars, the recordings on YouTube, and also the PDFs of the presentations on our website. So please do have a look back at those. Please do circulate them to colleagues who will be interested. I think it provides, a very, very good overview of so many countries' experiences during this pandemic, and also important research findings from a number of prominent groups. So thank you again for all of you. And I hope you have a wonderful Christmas season, which of course is coming up for many countries in the next few weeks.